Welcome back to another video in our lecture discussion about the female reproductive system. Today we will be talking about several topics such as the female sexual response, pregnancy and development, labor and parturition, and of course lactation. The nature of human sexual response study was pioneered by the Masters and Johnson Institute research team, and this is composed of William H. Masters and Virginia E. Johnson. They pioneered the research into the nature of human sexual response and the diagnosis and treatment of sexual disorders and dysfunctions from 1957 until the 1990s. In the initial phase of Masters and Johnson studies, from 1957 until 1965, they recorded some of the first laboratory data on the anatomy, psychology, and physiology of human sexual response based on direct observation of paid volunteers consisting of around 382 women and 312 men engaging in sexual activity, while hooked to wires in their lab in what they were conservatively estimated to be about 10,000 complete cycles of sexual response. So this figure talks about their continuous comprehensive study of the human sexual response prior to the publication of their work that led to the creation of the traditional model of the human sexual response, where the Masters and Johnson model outlined 4 stages of physiological stages, which is called, first is the excitement, and the next stage is called the plateau, then the orgasm, and of course resolution. Now let's first talk about the excitement phase. Excitement phase, or also known as the arousal or initial excitement phase, results in an increase in heart and breathing rates and in a rise of blood pressure. Vasocongestion of the skin, commonly referred to as the sex flush, will occur in approximately 50% to 75% of females. And during this sex flush, pinkish spots develop under the breast and then spread to the breast, torso, face, hands, soles of the feet, and possibly over the entire body. So vasocongestion is also responsible for the darkening of the clitoris and the walls of the vagina during sexual arousal. An increase in muscle tone, also called as the myotonia, of the levator ani muscles occurring voluntarily and involuntarily, and an intense sweating begins during this phase. Also, the external anal sphincter may contract upon contact or later during orgasm without contact. So basically what happens physiologically is that the labia minora increase in size and become more deeply colored. Then the clitoral shaft increases in size. The vestibular bulbs increase in size. The labium majora separate away from vaginal opening. The clitoris begins to engorge with blood. Also, the uterus is taking part in this phase where it elevates in the pelvic cavity, and the inner 2/3 of the vagina lengthens and expands. And lastly, the vaginal walls begin to lubricate. So, on sexual arousal, the blood supply to the vaginal epithelium is rapidly increased by parasympathetic inputs from the S2 to S4, and at the same time, the venous drainage is probably reduced, resulting in vasocongestion. The parasympathetic S2 to S4 inputs consist of paths from the pelvic plexus or pelvic nerve to cholinergic postganglionic fibers and to the bladder and sphincter. The increased blood flow to the genitals is activated by the VIP journey innervation of the large vessel supplying the epithelium and possibly aided by the calcitonin gene regulating peptide or what we call as the CGRP, and it is enhanced permeability of the capillary tufts, which allows the serum to leak out of blood vessels through the vaginal mucosa, where a fluid that passes through a membrane which filters out all of the cells that mash up the protein, yielding a watery solution, is called transidate. And a transidate acts as a lubricant during intercourse, which occurs immediately within 30 seconds of stimulation and longer if lying down. So the neuropeptide Y or NPY is a known vasoconstrictor, may be involved in constricting the venous drainage. There appears to be very little nitric oxide synthase or NOS in the blood vessels of premenopausal vagina and none in the postmenopausal. So during the excitement phase, the androgen-dependent glands of the vulvar vestibule or the Bartholins or skins secrete mucin to act as lubricant at the vaginal introitus or opening. So, in addition to the vascular changes during the excitement phase, the pubococcygeus muscle surrounding the vaginal opening tightens and the uterus elevates and increases in size. Meanwhile, the breasts increase slightly in size and the nipples become hardened and erect. So the next stage will be the plateau phase. So the plateau stage in females represent a continuation of the changes that occur during the excitement phase. The glans clitoris becomes extremely sensitive and withdraws slightly under the clitoral hood, and the vestibular glands produce further lubrication. The tissues of the outer third of the vagina swell, and the pubococcygeus muscle tightens, which reduces the diameter of the vaginal opening. So, this figure shows the different physiological events in plateau phase, where the clitoris withdraws under the hood. The uterus becomes fully elevated, and the inner 2/3 of the vagina is fully distended. The outer 1/3 of the vagina forms the orgasmic platform. So, orgasm is the conclusion of the plateau phase, and it is accompanied by quick cycles of lower pelvic muscle contraction. Between arousal and orgasm, there is an increase in vaginal luminal pressure. So, the smooth muscle layers contain a great variety of classical and peptidergic transmitters including serotonin, norepinephrine, acetylcholine, dopamine, vasoactive intestinal peptide or VIP, the NPY, gastrin-releasing peptide or GRP, thyrotropin-releasing hormone or TRH, CGRP, somatostatin, substance P, oxytocin, cholecystokinin or CCK, and relaxin. But the exact function of each neurotransmitter in sexual response is vague or somewhat unknown as of this time. A series of pelvic colonic striated muscle contractions occur at approximately 0.8 seconds interval, which gradually get longer and the contractions weaker. So they can last for 5 to 60 seconds, and these contractions are concomitant with the subjective feeling of orgasm. Voluntary contractions of the pelvic striated muscles do not give a feeling of intense pleasure but are often used to enhance arousal. So, during sexual response and up to orgasm, individual uterine contractions may occur, while during orgasm, a series of uterine contractions occur, mediated by the sympathetic nervous system via the hypogastric nerve. Orgasms are often associated with other involuntary actions, including the vocalizations and muscular spasms in other areas of the body, and a generally euphoric sensation. The heart rate is also increased even further during this phase of sexual arousal. So generally, what happens here in the orgasmic phase is that the uterine contractions beginning at the top or the fundus moves down toward the cervix. And then the inner two-thirds of the vagina remains motionless. 3 to 15 rhythmic contractions of orgasmic platform occurs. And then externally, the clitoris remains retracted under the hood. The orgasmic platform contracts, and the rectal sphincter contracts. On the other hand, the breast further increases in size and superficial veins become more visible, as the sex flush in the breast generally appears in this phase. Also, there is areolar engorgement, or where the nipple partially hides. Contrary with the males wherein the ejaculation marks the orgasm, no fluid ejaculation accompanies orgasm in the female. So orgasm is then followed by the resolution phase, which is a state of well-being during which the body is restored to its unstimulated state. So, which then brings us to the another phase called the resolution phase. The resolution phase occurs after orgasm, and the resolution allows the muscles to relax, the blood pressure to drop, and the blood to slow down from its excited state. The refractory period, which is part of the resolution phase, is the period during which a man is unable to orgasm again. While less common, women can also experience a refractory period. Although, according to Messrs and Johnson, women have the ability to orgasm again and very quickly as long as they have effective stimulation. They are, as a result, able to have multiple orgasms in a relatively short period of time. Though generally reported that women do not experience a refractory period and thus can experience an additional orgasm, or what we call as multiple orgasms. So soon after the first, for some women, the clitoris is very sensitive after climax, making additional stimulation initially painful. And after the initial orgasm, subsequent orgasms for women may also be stronger or more pleasurable as the stimulation accumulates. Few sperms reach the ampullae of the fallopian tubes near the ovarian ends of the tubes during the intercourse, and the transport of the sperm is aided by the contractions of the uterus and fallopian tubes stimulated by prostaglandins in the male seminal fluid. Oxytocin released from the posterior pituitary gland of the female during her orgasm also aids the transport of the sperm. The site of fertilization of the ovum is the ampulla of one of the fallopian tubes, which is located here. So, fertilization, as a review, the sperm first penetrates the multiple layers of granulosa cells called the corona radiata. Then the sperm binds and penetrates the zona pellucida. Once the sperm has entered the ovum, the second oocyte divides to form the mature ovum. The fertilized ovum contains 23 unpaired chromosomes of the male pronucleus and the 23 unpaired chromosomes of the female pronucleus, so it completes the 46 chromosomes. After fertilization, 3 to 5 days is required for transport of the fertilized ovum through the remainder of the fallopian tube into the cavity of the uterus. So the transport is affected by a weak fluid current in the tube resulting from epithelial secretion, and the beating of the ciliated epithelium that lines the tube toward the uterus also affects the transport. Weak contractions of the fallopian tube also contributes. Implantation. So the blastocyst remains in the uterine cavity an additional 1 to 3 days before it implants in the endometrium. So during this time, the blastocyst obtains its nutrition from the uterine and endometrial secretions called the uterine milk, and implantation normally occurs on about the 5th to 7th day after ovulation. The implantation results from the action or invasion of trophoblast cells over the surface of the blastocyst. So these cells secrete proteolytic enzymes that digest and liquefy the uterine endometrium cells. So this causes what we call as implantation spotting or bleeding. Also, some of the fluid and nutrients released are utilized for blastocyst growth. The trophoblast cells, uterine, endometrium cells, and other blastocyst cells form the placenta and the various membranes of pregnancy. Pregnancy. Pregnancy is also known as gestation. And it is the time during which one or more offspring develops inside the woman. The changes that occur in a woman's body during pregnancy may be compared to a revolution. The fetus imposes unique demands on maternal physiology, which undergoes profound changes during pregnancy. A considerable number of adjustments take place in most of the maternal organ systems. Such changes are needed to promote fetal growth and prepare the woman's body for delivery and lactation. The situation is optimal if her body is in excellent general condition, not only during pregnancy but also prior to conception. Knowledge of adaptive characteristics is very important in avoiding the treatment of perfectly normal physiological conditions. Okay, so now let's talk about the hormones associated with pregnancy. One of them is the human chorionic gonadotropin, or HCG, aka the pregnancy hormone. This is a hormone unique in pregnant women that is produced by the placenta after implantation, and the detection of this hormone by pregnancy test kits or blood tests during early pregnancy is used to determine if a woman is indeed bearing a developing child. This hormone unique in pregnant women is secreted by the syncytial trophoblast cells into the fluids of the mother, occurring 8 to 9 days after ovulation or shortly after implantation. The rate of secretion rises rapidly to reach a maximum at about 10 to 12 weeks of pregnancy. The secretion then decreases back to a lower value by 16 to 20 weeks and continue at this elevated level for the remainder of the pregnancy. So aside from being just a detector of pregnancy, of course, this hormone wouldn't be present without its own purposes. One purpose of HCG is that the HCG hormone causes persistence of the corpus luteum and prevents menstruation. The continued secretion of estrogens and progesterone by the corpus luteum maintains the decidual nature of the uterine endometrium, which is necessary for the early development of the uterus. But then, after the 13th to 17th week of gestation, the corpus luteum invulates slowly, which causes a drop of the HCG hormone in the woman's body. The HCG hormone was also found to cause an interstitial cell-stimulating effect on the testes of the male fetus, resulting in the production of testosterone in male fetuses until the time of birth. So, the fetal testosterone can induce the fetus to grow male sex organs instead of female organs, and also causes the testes to descend into the scrotum of the developing fetus. Now, another female hormone is involved, again in pregnancy this time, and this is no other than the estrogen. The corpus luteum isn't the only one that can secrete estrogen and progesterone, but also the placenta. Estrogen formation in the placenta are formed from androgenic compounds from the adrenal glands found in the kidneys of both the mother and the fetus, which is then converted by the trophoblast cells into estradiol. So this is the kidneys of the mother and the adrenal glands, and the kidneys of a fetus, and this is where the adrenal glands are located. The hormone estrogen plays certain important roles during pregnancy. These functions include the enlargement of certain organs of the mother, such as the uterus, breast, and these ductal structures in the external genitalia. Lastly, here on our list is the estrogen's ability to relax the pelvic ligaments of the mother, specifically her sacroiliac joints and symphysis pubis, in which this allows an easier passage of the fetus through the birth canal. Now here's another hormone that is secreted in moderate quantities by the corpus luteum at the end of pregnancy. This is no other than the progesterone. This hormone will be then produced largely by the placenta after some time. And there are certain roles that the progesterone play. One of them is its ability to cause the decidual cells to develop in the uterine endometrium, which play an important role in the nutrition of the early embryo. It is also known to decrease the contractility of the pregnant uterus, thus preventing abortion. The progesterone also contributes to the development of the conceptus or embryo even before implantation, because it increases the secretion of the mother's fallopian tubes and uterus to provide nutrients for the developing morula and blastocysts. And it also helps in preparing the mother's breast for lactation, along with the hormone estrogen. Another hormone that we will be talking about is the human chorionic somatomamotropin, or HCS. HCS is a polypeptide placental hormone, which is the human form of placental lactogen. Its structure and function are similar to those of human growth hormone. It is secreted by the placenta by the 5th week of pregnancy and increases progressively in direct proportion to the weight of the placenta, which makes its quantity several times greater than all other pregnancy hormones combined. It modifies the metabolic state of the mother during pregnancy to facilitate the energy supply of the fetus, as it has anti-insulin properties. Like the human growth hormone, HPL is encoded by the genes found in the 22 and 24th region of the chromosome 17 Q arm and was identified in the year 1963. So this hormone is vaguely understood, but there are a couple of possible important effects it plays. One is that it causes a decrease in insulin sensitivity and utilization of glucose in the mother, allowing large amounts of glucose available for the fetus. It is also thought to promote the release and utilization of free fatty acids in the mother for energy. Lastly, HCS also increases protein formation. So, almost all the non-sexual endocrine glands of the mother react with pregnancy due to increased metabolic load of the mother and the effects of the placental hormones of the endocrine glands. And that leaves us a number of glands connected in pregnancy processes. One of them is the pituitary gland. The anterior pituitary gland during pregnancy enlarges and decreases its production of hormones, namely the production of corticotropin, thyrotropin, and prolactin hormones. There is also a suppression of the secretion of follicle-stimulating hormone and luteinizing hormone, which is a feedback inhibition of placental estrogen and progesterone. There is also an increase of corticosteroid secretion of glucocorticoid and aldosterone hormones during pregnancy. Glucocorticoid helps mobilize amino acids from the mother's tissue to be used for synthesis of tissues in the fetus, while aldosterone, on the other hand, reabsorbs excess sodium from the mother's renal tubules, leading to fluid retention that might cause pregnancy-induced hypertension. Then there is an increase of thyroid gland secretion. What happens here is that the thyroid gland enlarges and increases its production of thyroxine, which is mainly due to thyrotrophic effect. There is also secretion of relaxin by the ovaries and placenta. It is secreted by the corpus luteum of the ovary and by the placenta. It causes relaxation of the ligaments of the symphysis, pubis, and as a result, softens the cervix of the pregnant woman at the time of delivery. So, signs of early pregnancy. We have here a few lists of early signs of pregnancy. The first one that is very noticeable is the nausea. Morning sickness can strike at any time of the day or night. It is one of the classic symptoms of pregnancy. For some women, the queasiness begins as early as 2 weeks after conception. The nausea seems to stem at least in part of rapidly rising levels of estrogen, which causes the stomach to empty more slowly. The pregnant woman also have a heightened sense of smell, so various odors such as foods choking, perfume or cigarette smoke may cause waves of nausea in early pregnancy. There are some hints and tips to help combat the effect of morning sickness. The next one is that there is headaches, faintness, or dizziness. Early in pregnancy, there is increased blood circulation caused by the hormonal changes that may trigger frequent, mild headaches. As your blood vessels dilate and your blood pressure drops, you may feel lightheaded or dizzy. Early in pregnancy, faintness also may be triggered by low blood pressure. Another symptom is when you feel bloated or you feel constipated. Constipation is another early symptom of pregnancy. An increase in progesterone causes food to pass more slowly through the intestines, and you may feel constipated and blocked as a result. Constipation can also increase feelings of abdominal bloating. The estrogen and progesterone levels will be high during pregnancy, and this increase can affect your mood and make you more emotional or reactive than usual. Mood swings are common during pregnancy and may cause feelings of depression, irritability, anxiety, or even euphoria. Your basal body temperature is your oral temperature when you first wake up in the morning. This temperature increases slightly soon after ovulation and remains at that level until your next period. If you've been charting your basal body temperature to determine when you ovulate, its continued elevation for more than 2 weeks may mean that you are pregnant. And then next is the frequent urination. During pregnancy, your body increases the amount of blood it pumps, and this causes the kidney to process more fluid than usual, which leads to more fluid in your bladder, of course. And the hormones also play a large role in bladder health. You may find yourself running at the bathroom more frequently or accidentally leaking. Unfortunately, all of these symptoms are not unique to pregnancy, so the best way to find out is to check with a pregnancy test kit and see the result to confirm your speculations. Now let's move on with the maternal physiology. When we're talking about pregnancy, we all know that aside from the miraculous reward, which is the baby that comes after, there is also many changes that occur to the mother as the pregnancy takes place. Here are some of the maternal physiological changes that occurs during pregnancy. The most contributing change that is also for the developing fetus is that the basal metabolic rate of the pregnant woman increases about 15% during the latter half of pregnancy. This is the reason behind the sensations of overheating of the mother while being pregnant. Blood flow through the placenta and maternal cardiac output also increases during pregnancy by about 30 to 40% than usual. Maternal blood volume also increases during pregnancy at about 30%. This is due to aldosterone and estrogens where they increase the fluid retention by the kidneys. Also, the bone marrow becomes increasingly active and produces extra red blood cells. As the mother's oxygen utilization is increased, so is the mother's minute ventilation, which increases by 50%. And this is due to the progesterone that increases the respiratory center's sensitivity to carbon dioxide. The rate of urine formation by a pregnant woman is usually slightly increased because of increased fluid intake and decreased load of excretory products. This is where the renal tubules reabsorb the capacity for sodium chloride and water is increased, and as a result, the renal blood flow and glomerular filtration rates increase due to the renal vasodilatation by 50%. Weight gain and pregnancy. Did you know that pregnancy in women is known to bring about 25 to 35 pounds, which is about 11 to 15 kilograms of weight gain? The weight contributes of fetus, amniotic fluid, placenta, fetal membranes, the uterus, the breast, extra fluid in the blood, and ECF, and fat accumulation. But of course, an increased desire for food during pregnancy is the main contributory factor of all. So that wraps up everything of the maternal physiology, and we can now move on with fetal development. We will start our fetal development discussion on the first trimester of the pregnancy. Everything here is literally the start of everything. Week 1 is the conception stage and is counted by 2 weeks after the last period began. So what happens here is that the healthcare provider will count ahead 40 weeks from the start of last period. This means that the period is counted as part of the pregnancy. So, week 2. The sperm and egg unite in the fallopian tube to form a one-celled entity called a zygote. If more than one egg is released and fertilized, multiple zygotes occurs. The zygote has 46 chromosomes, 23 from female and 23 from male. These chromosomes contain genetic material that will determine the baby's sex and traits such as eye color, hair color, height, facial features, and at least to some extent, the baby's intelligence and personality. Soon after fertilization, the zygote will travel down one of the fallopian tubes toward the uterus. At the same time, it will begin dividing rapidly to form a cluster of cells resembling a tiny raspberry. So the inner group of cells will become the embryo, and the outer group of cells will become the membranes that nourish and protects it. With reimplantation. The zygote, by this time made up of about 500 cells, is now known as a blastocyst. When it reaches the uterus, the blastocyst will burrow into the uterine wall for nourishment. The placenta, which will nourish the baby throughout the pregnancy, also begins to form. And by this time, pregnancy tests will be positive. On the 4th week of fetal development, the embryonic period begins. The embryo is now made up of 3 layers at this time. The top layer, the ectoderm, will give rise to a groove along the midline of the baby's body. This will become the neural tube where the baby's brain, spinal cord, spinal nerves, and backbone will develop. The baby's heart and the primitive circulatory system will form the middle of the layer of cells called the mesoderm. This layer of cells also serve as the foundation for the baby's bones, muscles, kidneys, and much of the reproductive system. The inner layer of cells, the endoderm, will become a simple tube lined with mucous membranes. The baby's lungs, intestines, and bladder will also develop here. On the 5th week of fetal development, the baby's heart begins to beat. At week 5, which is 2 weeks from conception, the baby is 1/17 of an inch long, which is about the size of the tip of the pen. So it's very, very small. By this week, the baby's heart and circulatory system are taking shape. The baby's blood vessels will complete a circuit, and his or her heart will begin to beat. The motion of baby's beating heart is detected with an ultrasound exam. With these changes, circulation begins, making the circulatory system the first functioning organ system. At 6th week, the neural tube closes. Growth is rapid during the 6th week. And just 4 weeks after conception, the baby is about 1/8 of an inch long. The neural tube along the baby's back is now closed, and the baby's heart is beating with a regular rhythm. Basic facial features will begin to appear, including an opening for the mouth and passageways that will make up the inner ear. Digestive and respiratory systems begin to form as well. Small blocks of tissue that will form the baby's connective tissue, ribs, and muscles are developing along the baby's midline. Small buds will soon grow into arms and legs. At 7th week, the umbilical cord appears. The baby is 1/3 of an inch this time, a little bigger than the top of a pencil eraser. He or she weighs less than an aspirin tablet. The umbilical cord, which is the link between the baby and the placenta, is now clearly visible. The cavities and passages needed to circulate spinal fluid in baby's brain have formed, but baby's skull is still transparent. The arm bud that sprouted last week now resembles a tiny paddle, and the baby's face takes on more definition this week as a mild perforation, tiny nostrils, and ear indentations become visible. At week 8, the baby's fingers and toes form. Just 8 weeks into pregnancy, the baby is just over 1/2 of an inch long. The baby will develop webbed fingers and toes this week. Wrists, elbows, ankles are clearly visible, and the baby's eyelids are beginning to form. The ears, upper lip, and tip of the nose also become recognizable. As the baby's heart becomes more fully developed, it will pump at 150 beats a minute, about twice the usual adult rate. At the 9th week, the movement begins. The baby is now nearly 1 inch long and weighs a bit less than 1/8 of an ounce. The embryonic tail at the bottom of baby's spinal cord is shrinking, helping him or her look like less of a tadpole and more like a developing person. The baby's head, which is nearly half the size of his or her entire body, is now tucked down into the chest. The nipples, hair follicles, begin to form. The baby's pancreas, bile ducts, gallbladder, and anus are in place. The internal reproductive organs, such as the testes or ovaries, start to develop at this time. And also, the baby may begin moving by this week. On the 10th week, the neurons multiply. By now, the baby's vital organs have a solid foundation. The embryonic tail has disappeared completely, and the baby has fully separated fingers and toes. The bones of the baby's skeleton begin to firm. This week, the baby's brain will produce almost about 250,000 new neurons every minute. The baby's eyelids are no longer transparent. The outer ears are starting to assume their final form. The tooth buds are forming as well. If the baby is a boy, his testes will start producing the male hormone testosterone. At week 11, the baby's sex may be apparent. From now until the 20th week of pregnancy, the halfway mark, the baby will increase his or her weight 30 times and will about triple in length. To make sure the baby gets enough nutrients, the blood vessels in placenta are growing larger and multiplying. So, by this time, the baby is now officially described as a fetus. The baby's ears are moving up and to the side of the head of this week. By the end of the week, the baby's external genitalia will develop into the recognizable penis or clitoris and labia majora. By the 12th week, the baby's fingernails and toenails appear. 12 weeks into pregnancy, the baby is nearly 3 inches long and weighs about 4/5 of an ounce. This week marks the arrival of fingernails and toenails. The baby's chin and nose will become more and more refined as well. At second trimester, as the pregnancy progresses, the baby begins to seem more real. The growing abdomen on the mother becomes more noticeable at this time, and you can also hear the heartbeat at prenatal appointments. During this time, the baby is quickly maturing. 2 months ago, the baby was simply a cluster of cells, but now he or she has functioning organs, nerves, and muscles. 13th week is the start of the second trimester. This is where baby flexes kicks in. The baby can move in a jerky fashion, sometimes flexing the arms and kicking the legs. And during this week, the baby might even be able to put the thumb in his or her mouth. The baby's eyelids are fused together to protect his or her developing eyes. The tissue that will become the bone is developing around the baby's head and within the arms and legs. Also, tiny ribs may soon appear. On week 14, hormones gear up. The effect of hormones become apparent at this week. For boys, the prostate gland is developing, and for girls, the ovaries move from the abdomen into the pelvis. Meconium, which will become the baby's first bowel after the birth, is made in the baby's intestinal tract. By the end of the week, the roof of the baby's mouth will be completely formed. At 15th week, the skin begins to form. The baby's skin starts out nearly transparent. Eyebrows and scalp hair may make an appearance. For babies destined to have dark hair, the hair follicles will begin producing pigment. The bone and marrow that make up the baby's skeletal system are continuing to develop this week. The baby's eyes and ears now have a baby-like appearance, and the ears have almost reached their final position. On the 16th week, facial expressions on the baby are now possible. The baby is between 4 and 5 inches long and weighs a bit less than 3 ounces during this time. He or she can now make a fist, and the baby's eyes are becoming sensitive to light. There's more developed facial muscles, which may lead to various expressions such as squinting or frowning, and the baby may have frequent bouts of hiccups as well. For girls, millions of eggs are forming in the ovaries. At week 17, fat accumulates. Fat stars begin to develop under baby skin during this week. The fat will provide energy and help keep the baby warm after birth. On week 18, the baby begins to hear. As the nerve endings from the baby's brain hook up to the ears, the baby may hear the mother's heart beating, the stomach rumbling, or the blood moving through the umbilical cord. He or she may even be startled by loud noises, and the baby can now swallow this week too. On week 19, the lanugo covers the baby's skin. The baby's delicate skin is now protected with a pasty white coating called the vernix. Under the vernix is fine down-like hair called lanugo, which covers the baby's body. The baby's kidneys are also producing urine at this time, and the urine is excreted into the amniotic sac, which surrounds and protects the baby. As the baby's hearing continues to improve, he or she may pick up the mother's voice in conversations, although it's probably hard to hear clearly through the amniotic fluid and protective paste covering the baby's ears. On week 20, the halfway point is here. Halfway into pregnancy, the baby is about 6 weeks long and weighs about 9 ounces, a little over half a pound. The mother can now probably begin to feel the baby's movements. Under the protection of pasty white coating called the vernix, the baby's skin is thickening and developing layers. And now the baby has thin eyebrows, hair on the scalp as well, and also well-developed limbs. So during the 6 months, there is a development of sense of balance. By now, the baby weighs about 1.5 pounds. Footprints and fingerprints are also forming. Fully developed inner ear, which controls balance, happens here, and he or she may have a sense of whether he or she is upside down or right side up in the womb. The babies born at 24 weeks have more than 50% chance of survival, and the odds get better with every passing week. Still, complications are frequent and serious. On the 27th week, the second trimester ends, and this marks the end of the second trimester. The baby's lungs, liver, and immune system are continuing to mature, and he or she has been growing like a weed. At 27 weeks, the baby's length will have tripled or even quadrupled from the 12-week mark. If the baby is born this week, the chance of survival is at least 85%. But then, for serious complications, is still possible. Now let's move on with the 7th month or week 28 of fetal development. Week 28 is the start of 3rd trimester, and the baby by this time is about 15 inches long and weighs about 2 to 3 pounds. The baby's eyes are open and can now close. The color has also been established. The eye color may change within the first 6 months of life, especially if the baby's eyes are blue or gray-blue at birth. At this time, the baby is now sleeping for about 20 to 30 minutes at a time. Fetal movement will also be obvious when sitting or lying down. On month 8, the downy hair falls off, and the baby is between 15 and 17 inches long and weighs about 4 to 4.5 pounds. Nearly all babies born at this age survive the challenges of premature birth. The layer of soft, downy hair that has covered the baby's skin for the past few months, known as lanugo, starts to fall off this week, and as space in the uterus becomes more cramped, the baby kicks and other movement may seem less forceful. On the 9th month, the baby can suck. The baby is between 16 and 19 inches long and weighs about 6.5 pounds. The recent fat deposits have rounded out the baby's face, and the baby's powerful sucking muscles are ready for action. To prepare for birth, the baby may descend into the head-down position, and by the end of this week, the baby will be considered full term. On the 40th week, the due date arrives, and the baby may be 19 to 21 inches long and weigh 7 to 8 pounds. After the 40th week, parturition occurs. Parturition means birth of the baby. During this time, there is increased uterine excitability near the term, and progressive hormonal changes that cause increased excitability of the uterine musculature happens. There is also progressive mechanical changes. And of course, there are certain hormonal factors that increase uterine contractility. One of them is the increased ratio of estrogens to progesterone. Progesterone inhibits while estrogen increases uterine contraction during pregnancy. Estrogen to progesterone ratio increases sufficiently toward the end of pregnancy. Oxytocin causes contraction of the uterus. The rate of oxytocin secretion by the neurohypophysis is considerably increased at the time of labor, and the stretching of the uterine cervix can cause a hypothalamic neurogenic reflex. There are also mechanical factors that increase the uterine contractility. First is the stretch of the uterine musculature and the stretch of or irritation of the cervix. The stretching of smooth muscle organs increases contractility of the uterus. And for the cervix, usually the obstetrician frequently induces labor by rupturing the membrane so that the head of the baby stretches the cervix more forcefully than usual. In here, there is stretching of nerves in the cervix that initiates the reflexes to the body of the uterus, and the myogenic transmission of signals from the cervix to the body of the uterus. Onset of labor is caused by a positive feedback mechanism. We have two types of labor called the Braxton-Hicks contraction and the labor contractions. Braxton-Hicks contraction is the periodic episodes of weak and slow rhythmical contractions during most of the months of pregnancy. This is where it becomes progressively stronger toward the end of pregnancy. On the labor contractions, the strong contractions result in final parturition. Abdominal muscle contractions during labor. Pain signals originate both of the uterus and from the birth canal, elicit neurogenic reflexes in the spinal cord to the abdominal muscles, causing intense contractions of these muscles. The abdominal contractions add greatly to the force that causes expulsion of the baby. Mechanics of parturition. Each uterine contraction ends to force the baby downward toward the cervix. Labor contractions begin at the top of the uterine fundus and spread downward over the body of the uterus. The intensity of contraction is great in the top and body of the uterus, but weak in the lower segment of the uterus adjacent to the cervix. Contraction frequency, usually early in labor, it occurs once every 30 minutes and then eventually once every 1 to 3 minutes. The contractions of labor occur intermittently to avoid stopping blood flow through the placenta. So for 10 to 45 minutes after birth of the baby, the uterus continues to contract to a smaller and smaller size. This shears and separates the placenta from the walls of the uterus. Placental separation opens the placental sinuses and causes bleeding, but limited to an average of 350 milliliters by the following mechanism. First, the smooth muscle fibers of the uterine musculature are arranged in figures of 8 around the blood vessels as the vessels pass through the uterine wall. So, contraction of the uterus after delivery of the baby constricts the vessels that had previously supplied blood to the placenta. Next is vasoconstrictor prostaglandin formed at the placental separation site. Labor pains or cramping pains occur in early labor, and this is probably caused mainly by hypoxia of the uterine muscle resulting from compression of the blood vessels in the uterus. It also affects the hypogastric nerves. Then later on, when the fetus is being expelled through the birth canal, pain becomes more and more severe. It is caused by cervical stretching, perineal stretching, and stretching or tearing of structures in the vaginal canal itself. The pain is also caused by the somatic nerves. During the first 4 to 5 weeks after parturition, the uterus involutes. So this causes decreases in weight, suppression of pituitary gonadotropin, and ovarian hormone secretion during the first few months of lactation. Placental site on the endometrial surface autolyzes, causing a vaginal discharge known as lochia, which is the first bloody and then serous. The endometrial surface becomes re-epithelialized and ready for normal, non-gravid sex life again. Development of the breast. The breast begins to develop, or the glandular tissue, at puberty, but it is only during pregnancy that the development of the glandular tissue is complete and has the ability to produce milk. Development is stimulated by the estrogens of the monthly female sexual cycle. Estrogens stimulate growth of the breast, mammary glands plus the deposition of fat to give the breast mass. There are also hormones that regulate lactation. 4 other hormones are important for growth of the ductal system, namely the growth hormone, prolactin, the adrenal glucocorticoids, and insulin, which has a role in protein metabolism. So progesterone is required for full development of the lobular-alveolar system, budding of alveoli, and development of secretory characteristics in the cells of the alveoli. Prolactin promotes lactation. Prolactin is secreted by the mother's anterior pituitary gland. The blood prolactin concentration rises steadily from the 5th week of pregnancy until birth of the baby. The hormones estrogen and progesterone also inhibits the actual secretion of milk. Placenta secretes large quantities of human chorionic somatomamotropin that has lactogenic properties. Colostrum. Colostrum is a form of milk produced by the mammary glands of mammals in late pregnancy and the first few days of parturition. It contains antibodies to protect the newborn against diseases as well as being lower in fat and higher in protein, which means It has growth hormones, enzymes, etc. than ordinary milk. It has some laxative effect, passing the baby's first tube. A number of cytokines or small messenger peptides that control the functioning of the immune system are also found in the colostrum. The colostrum also contains a number of growth factors such as insulin-like growth factors 1 and 2, fibroblast growth factors, epidermal growth factor, granulocyte macrophage stimulating growth factor, platelet-derived growth factor, vascular endothelial growth factor, and colony stimulating factor 1. Hormonal regulation of lactation. Immediately after birth, secretion of both estrogen and progesterone from the placenta decreases, which allows lactogenic effect of prolactin. Each time the mother nurses her baby, the nervous signals from the nipples to the hypothalamus cause an intermittent 10 to 20-fold surge in prolactin secretion that lasts for about an hour. So, if this prolactin surge is absent or blocked as a result of hypothalamic or pituitary damage, or if nursing does not continue, the breasts lose their ability to produce milk within 1 week or so. However, milk production can continue for several years if the child continues to suckle, although the rate of milk formation normally decreases considerably after 7 to 9 months. Prolactin and oxytocin. Suckling on one breast causes milk flow not only in that breast but also in the opposite breast. It is especially interesting that fondling of the baby by the mother or hearing the baby crying often gives enough of an emotional signal to the hypothalamus to cause milk ejection by the production of the pituitary gland of two hormones, namely the oxytocin, which is concerned with releasing or ejection of milk, and of prolactin, that is concerned with synthesis and production of milk. Ovarian cycles in nursing mothers. In most nursing mothers, the ovarian cycle does not resume until a few weeks after cessation of nursing. The reason behind this is that the same nervous signals from the breast to the hypothalamus that cause prolactin secretion inhibit secretion of GnRH by the hypothalamus, thus suppressing formulation of the LH and FSH. However, after several months of lactation, in some mothers, especially in those who nurse their babies only some of the time, the pituitary begins to secrete sufficient gonadotropic releasing hormones to reinstate the monthly sexual cycle, even though nursing continues. Inhibition of milk ejection. Psychogenic factors or even generalized sympathetic nervous system stimulation throughout the mother's body can inhibit oxytocin secretion and consequently depress milk ejection. Many mothers must have an undisturbed period of adjustment after childbirth if they are to be successful in nursing their babies. Composition of milk. The mature milk contains an average of 750 kilocalories per liter of energy. It also has lipids, which is 38 grams per liter, casein, whey, non-protein nitrogen, lactose, and it also has a white appearance because it is due to the presence of the emulsified lipids, partly to the presence of the calcium salt of casein. And did you also know that the pH of milk is 6.6 to 6.8? The volume at the height of lactation that the human breast can produce is up to 1.5 liters of milk, or about 50 fluid ounces. Some of the immunologic components of human milk includes immunoglobulins, lactoferrin, lysozyme, mucins, leukocytes, and some others. The human milk also contains various enzymes. Some are specific for the biosynthesis of milk in the mammary gland, such as lactose synthetase, fatty acid synthetase, and thioesterase. Others are specific for the digestion of proteins, fats, and carbohydrates that facilitate the infant's ability to break down the food and to absorb human milk, such as lipase and protease amylase. Certain enzymes also serve as transport maltase for other substances such as zinc, selenium, and magnesium. Some have antimicrobial activity such as lysozyme. The human milk also has a lot of minerals. The most important salts are calcium, sodium, potassium, and magnesium. Calcium is also important and it is representing of the predominating mineral. Human milk versus cow's milk. Human milk has a higher content of water and lactose, but a lower content of protein compared to cow's milk. In babies, replacing or supplementing breast milk by appropriate milk supplements formulated for infants is okay, but however, cow's milk should be avoided. This is because the cow's milk lacks some of the key immunological components that are required by the human infant, and the foreign proteins may trigger allergic reactions in some babies. And most importantly, certain vitamins and minerals that are necessary for human development may be lacking in cow's milk, which gives us no doubt that breastfeeding is indeed still the best option for babies. So here are some of the references that I used during this discussion, and that ends our lecture on the female reproductive system. Thank you for watching, and I'll be hoping to see you again next time.